Yeah, there's no question. So, one of the, just to kind of start this process, so the biggest challenge, and unfortunately there's not a lot of treatment out there, are these, what we have talked about, these M0 patients. So you've got this patient that basically prostate cancer, hormonal therapy, testosterone less than 50, rising PSA. The big bugaboo that a lot of the urologists have is, okay, we have historically used our monitoring schemes that we have employed for localized disease in hormone-naive patients. We've used the same monitoring scheme for patients once they get on hormonal therapy. And I'm completely convinced that these are two separate disease states, if you will, and that we have to do a better job in this early identification, because we all know that despite the fact that radiographically they don't have METs, we know that within a couple years they're going to develop METs, and most of these patients actually have micrometastases. So, Ken, that M0 patient, how do you guys manage that at MIT?
Obviously, I think that's the patient that has a tremendous amount of anxiety. Their PSA is starting to go up. We joke about patient-stimulating anxiety as that PSA rises, and to say, hey, we don't really have anything to offer you necessarily is a challenge for them. So we do it a couple ways, and I think Dr. Cheatham her point was well taken, that we're probably not imaging these people enough. So as these patients start to fail and their PSAs start to rise, we make sure they get a bone scan and a CT scan just as that PSA starts to rise. If we don't find any demonstrable evidence and we really think they do have it, a lot of times we'll get a sodium fluoride PET test. Sometimes that'll identify the disease. And then, we're fortunate enough at our research institute, we have an M0 trial for these patients. So those patients really like that because they feel like, hey, I'm actually doing something for my disease as opposed to waiting till I actually have metastasis and then have to do something. So they feel good that they don't have to delay treatment.
So Neil, we were on a panel that discussed looking at this when to image. Can you want to talk about that a little bit in terms of what some of the recommendations are that came out of that RADAR working group?
Yeah, I think before even answering that, this is such an important question because there's been this historic nihilism about why order a diagnostic test, why get a CAT scan or a bone scan. Historically, when we had nothing to offer patients, and as you really correctly point out, at the M0 patients, we have no level 1 evidence for therapy. We do these various second-line hormonal manipulations to modulate PSA. But when we can show someone's converted from M0 to M1, whether it's NCCN or the AUA CRPC guidelines, there's now level 1 evidence of actionable information or a real change in what we can offer patients, whether it's an immunotherapeutic, an oral hormonal agent, or even chemotherapy, or potentially, if they're symptomatic, a radium-223. So now the need to think about ordering tests more proactively, where historically we never did. We didn't have anything to offer. And I think a lot of our colleagues are still trying to figure out this explosion, this burgeoning information. And so there's a bit of a confusion out there. So the RADAR paper that you're talking about got published in Urology last month. Was a consortium of folks. So you and I were on this group, and I think Dave Crawford's the first author in it. And we kind of looked at all the different guidelines of different organizations worldwide, what they're recommending regarding the CRPC population. And we came up with sort of a consensus statement. And when it came to the M0 CRPC group, we all essentially agreed that from when someone is CRPC, T level less than 50, rising PSA, get baseline scans. Because there is a small percentage of patients who will clearly have radiographic evidence of disease. That's important because now you can treat them. The next thing we pretty much looked at was trying to get a consensus was looking at PSA kinetics as opposed to it just being a calendar event time to order the testing. And so rapid PSA doubling times, absolute PSA, but really anything with a PSA doubling time of less than 6 months for sure, repeat scans, and then if not, potentially even on an annual basis.
And I think the one thing, I think your point is very well taken, and I think the medical oncology world has recognized this. I think the urologists have been very loath to scan, number one, because we didn't have a lot of therapy. Number two, many of these patients are asymptomatic as they walk through the office. It's difficult for them to believe that they are advancing with their disease, being asymptomatic, feeling well. But again, I think we have put this emphasis on PSA, knowing that that is not necessarily the end-all be-all in terms of how we need to evaluate these patients. So, Mike, do you have a particular trigger? If you've got this M0 patient, and whether it's you or your practice, do you have a particular trigger point where you are going ahead and start the scanning process? Is it like Neil said, is it a gestalt with the doubling time? Is there an absolute value where you'll start?
I think the way Neil said it is perfect. The very beginning thing, and it's something that I know medical oncologists do all the time, but trying to get urologists to understand, is about extent of disease evaluation. That baseline imaging is so important, and if you don't do that, you're really never going to find out. We know from several trials that patients in which we're trying to enroll them on M0 trials, that between 20 and 30% of those patient populations will have metastasis at that time. And so identifying that baseline scan is of utmost importance. So as far as continuing scans, I think there's a difference that you kind of have to utilize. PSA kinetics is important. If you've got a person that has got a rising PSA, but it's going like 2 to 3 to 4 over a year's time frame, that's not as significant as someone that's going from 2 to 8 to 12 to 25 to 40. And in those kind of situations, we need to be more adept at imaging. I think the annual imaging for these kind of patients is important, but again, all of that has to be taken into account with all the PSA kinetics.
I also think it's not just about scanning, it's about where the patient goes for the scan. It's about remembering that we need to give our radiologists the right information. What questions are we trying to answer by doing the scan? And I think the baseline is important because it's not just about when you're scanning, but having something to compare with is extremely valuable. And I often tell my patients, if you're going to a different center, try and get hold of your previous imaging on a CD and hand it in when you're going for your next scan and say, please ask the radiologist to report this in conjunction with my previous scan, because comparison is phenomenal. And we also know with scanning, it's not always black and white. We know that patients who have metastatic disease that may have improved, the scans can look worse when actually the disease is healing. So I think we need to collaborate and communicate with not just our medical oncology colleagues and radiation colleagues, but also remember that the best information we get from a scan is the information that we provide to the radiologist. And if you want to answer a definitive question, remember to pick up the phone and speak to the radiologist and say, this is the question I want answering, and what is the best task to answer that question?
Yeah, no, there is no question that the radiologists are kind of out there flying by the seat of their pants. I think that's a point well taken to communicate exactly, what their disease, where they are, what they've had done, et cetera.
But I also think that it's important because the radiologist may not know that by actually distinctly saying that this is consistent with metastatic disease, we now can offer them treatment.
Right.
And that's been an education we've tried to do, to go back to our hospital radiologists to say, look, you're actually helping these people if we can declare that this is consistent with metastatic disease. So you're right, it's been an education for them to help the patient.
I mean, I also think particularly with bone scanning, many of these patients have sustained fractures, may have got some compression fractures, may have arthritic changes, and all of those need to be taken into the equation, and that's where having good scans to compare is extremely useful.
Dr. Sartor, speaking